Okay. You guys know the email is the best way to reach me. I saw a couple Linowit questions. I answered those. So again, you can kind of post questions to those as we go through today. I'll check them towards the end of class. You have an hour till the test, right, after I finish up. So if I'm just standing up here and you guys ask questions of me, I'll just keep standing here talking until you guys stop asking questions, okay? So. Yeah, all the question askers out there. That's what the sticky board's for there. So you can ask questions if you're uncomfortable asking questions out loud, right? So that's the whole point. Anywho, so let's kind of blast through and finish up this this cardiology stuff here. Now, one big group that we haven't really talked about previously is our anticoagulants. We've worked up through our antiplatelets. Now we have to actually work on the clotting factors specifically. And have you covered the clotting cascade before? A little bit. A little bit. Okay. So you've seen something akin to this previously. Okay. Not like that.
It was like condensed.
Condensed.
And like this.
You guys are going to be PAs. Physician's assistant. Like, you got to know the whole cascade.
Yeah. In our defense, we haven't done hematology yet.
Okay. In your defense, you haven't done hematology. That's okay. We're going to go through what's important for my purposes right here. Let's bring it in, wrap it in. Okay. So big things to note here, right? So the clotting cascade, this is what's occurring when you have vascular injury, right? So again, you're going to find there's two main pathways here, and they will meet up in a common pathway, okay? We have what we call the intrinsic pathway. It has its own specific set of clotting factors that are going to be associated with it, okay? Now again, when I'm going through specific factors, I'm going to kind of hone in on certain ones. Certain drugs will affect certain ones. Those are the ones you want to kind of key in on, okay? So if you notice here, we're going to find that when you're doing your monitoring, when you check your coags, you guys are familiar with what kind of labs you check with coags? What are some examples? PT-INR, APTT. Those are kind of the big ones you're going to be looking at. These are going to be represented by the different, the intrinsic and the extrinsic systems here. So usually when you're looking at the intrinsic system, this is going to be more of the APTT you're kind of looking at. So you have things like 12, 11, 9 are getting involved here. Again, remember, this is a positive feedback loop, because when you have these platelets starting to activate and you have this injury, you're trying to cause this positive feedback loop to get that fibrin formed, so that way you can cause that stable clot to form there. The extrinsic pathway is going to be involving factor 7. This is where you're going to see your PT-INR getting more involved here, okay? So anyway, basically what they're going to do is meet up with the common pathway here, okay? So this is where you're going to find factor 10 is really important here. And factor 2 is another really important one as well, okay? So think about when you're driving 10 and 2, right? Hopefully not selfie or makeup or whatever else you're doing while you're driving, but 10 and 2, think about that. Those are the important factors of the common pathway, okay? Now 2 is really important because this is when you get conversion from prothrombin to thrombin. Thrombin is the thing that actually kicks off the formation of fibrin. Fibrin is really important because that's what's the spider web that's kind of holding all those platelets together, okay? That's what's stabilizing that clot finally, okay? And eventually we're going to need to break that down because you don't want clots everywhere. You want them to go away when the injury is healed. So we'll look at how we can deal with that as well a little bit later on, okay? So, and you're going to see there's lots of different things that will inhibit this system as well, because it's important that you don't have just unchecked sort of clotting everywhere, because then it'd be bad, right? You'd have emboli everywhere. That's no good. So we're going to have things like antithrombin 3 is going to be really important. This is big for helping to inactivate a lot of clotting factors. This is where heparin is going to come into play, okay? We're going to have things like protein CNS. This is going to be important when we talk about things like warfarin a little bit later on. So just know that there's different factors that are out there that are trying to keep the system in check to prevent too much clotting from occurring. So heparin's a big one we're going to talk about first. This is a product that we naturally form ourselves, and basically what this does is help antithrombin 3 to work faster, right? This is helping to catalyze that reaction more quickly, so that way you can help to break down several clotting factors, okay? 10 and 2 are going to be some of the big ones we're going to be focusing on, but there's some others as well. And notice heparin is just kind of a big, long sugar molecule, very, very large molecule, and so when you have a big molecule like that, is that easy to absorb, say, from like the GI tract? No, plus our GI tract's pretty good at digesting sugars anyway, so this is not something you can give orally. You have to give it either subcutaneously or we'll give it via IV to get into the system to cause anticoagulant effects there. So big, long molecule. This is important to consider because when we start talking about low molecular weight heparins, it's an offshoot of heparin. Those are basically shorter molecules, essentially. If you kind of chop up the heparin molecule, you get shorter versions, and those will be some other drugs we'll talk about in just a few moments here. So anyway, the mechanism here is going to bind to antithrombin 3, and this will facilitate the breakdown and inactivation of several factors. The biggest ones we're going to focus on are 10 and 2. So think about 10 and 2. And then you also have 9, 11, and 12. So if I were to ask you on a specific test question, what does heparin inactivate, you're going to say things like 2, 10, 9, 11, and 12. Okay. So that means that we're going to be having increased activity about 1,000-fold. So you're going to get very good anticoagulant sort of activity here by inactivating those factors there. And so when do you think you might use heparin? What is the indication? Yeah, so you have a PE. PE is usually developed from what? DVTs. Good. What else? Yeah, percutaneous coronary intervention. If I need to make sure I'm not clotting off when I'm trying to revascularize those coronary vessels. Yeah, anywhere we want to basically prevent these clots from forming, ischemic strokes potentially. Like, there's lots of different places we're going to be using heparin to help hopefully prevent either further clots from forming or to try to break down the clots that are already kind of there, right? To help kind of prevent them from propagating. So, just to give you kind of a pictorial sort of example here, imagine this is the unfractionated heparin. When you see unfractionated heparin, that's referring to just the normal heparin molecule, okay? It's going to be binding up to antithrombin 3, and then you can see how it's long enough that it can facilitate the binding to both factors 10 and 2. Now, notice the length here is going to be important because this is going to come up when we talk about the activities of the low molecular weight heparins in a few minutes, okay? So basically, we're going to either be given this IV or sub-Q. Now, we can give this for actual acute treatment of a clot. So if you were to have an actual DVT or a PE, we can give you treatment doses. Or in a lot of cases, if you're at high risk for a clot, we can give you prophylactic doses. So very frequently, you'll see patients in the ICU or they're post-surgery. They will get prophylactic doses of heparin to prevent a clot from occurring in the first place, right? It's a lot easier to treat one before it happens than to treat afterwards, right? Just know that this is also preferred in a lot of cases for pregnant patients because it's a big molecule, it doesn't cross into the breast milk. And we do know that pregnant patients tend to be hypercoagulable. That's one of those things you worry about in those pregnant patients there. And just know that usually it is fairly short acting, so oftentimes this is given via continuous infusions. You have to kind of give it continuously, especially for those treatment sort of doses, to make sure you keep them anticoagulated for the duration when they're kind of at that big risk there. So the way we monitor this, and this is important because, again, I'm going to ask you on a test question, which of these drugs is monitored via APTT, or which of these is going to be monitored via PT-INR? You want to know those associations very well because, again, what's the big risk with any of these anticoagulants? Bleeding. So you need to be able to, do you want to wait until the patient actually has a bleed? No. Can you always see the bleeds when they occur? No, but you can look at the lab values, right? You can look to see, are they too anticoagulated? Are they at risk for developing a bleed in those cases? Okay, so APTT, you're thinking heparin, okay? Or to ask you on a test question, which of these is monitored with APTT? You're going to say heparin. Fantastic, good. Typically, you're using a ratio, so you're going to take what the baseline normal value is of a person who wasn't on a heparin, and then comparing it to what their value is now that they're on heparin. Usually shooting for like 1.5 to 2.5. Now, anyone know how APTT is normally measured? What's the units? So it stands for activated partial thromboplastin time. Time is the key thing here, so it's in seconds. So you're measuring how long it takes for that blood to clot, essentially. And so when you give more heparin, what do you think that number is going to do? It's going to go up. It takes longer for that blood to clot because I'm inhibiting those factors there, okay? So APTT should go up, that ratio should go up, and so you're looking for a particular number of seconds in a lot of cases when you're treating these patients there. As I mentioned, indications, VTE, pulmonary embolism, MI, coronary angioplasty, a lot of different places we're going to see this being used, and a lot of times we're using it as prophylaxis to prevent a clot from happening in the first place, right? Because again, why did DVTs form in the first place?
Endothelial injury, surgery.
Yeah, but let's think about someone who's like, say they're laid up in the ICU. So maybe hypercoagulable, but also if you're just laying around all the time, the venous stasis is a big thing, right? So again, if you think about someone who's like on a long plane flight, so I took a plane over to LA, that's like 5 hours. Like, it was a long flight, So again, if I was in a hypercoagulable sort of state there, it could stand to reason I could develop a DVT in those cases there. Sometimes we'll give patients heparin prophylactically to prevent that from actually occurring if they're really at high risk there. So a lot of different indications we may be using heparin for. But again, as I mentioned, bleeding is going to be the major toxicity here. And one of the other big things to think about, this is rare, but occurs, something you want to be at least monitoring for because it can be life-threatening, is what we call heparin-induced thrombocytopenia. So if you ever heard of HIT, that's what we're referring to. Basically, it's an autoimmune reaction where you're developing antibodies against heparin along with this, what we call platelet factor 4. And so essentially, you're going to see that after about 5 to 10 days or so of a patient receiving heparin, they're going to develop this drop in their platelets. You think, well, where did all the platelets go? It's not that they disappeared, but the fact they're actually activated. So you may think that, okay, well, if you have a patient with thrombocytopenia, you'd expect them to be at risk for bleeding, but actually this patient's clotting off everywhere, right? Because that's why you can't measure the platelets because they're not circulating in the bloodstream more. They're clotting off kind of everywhere. So in those cases there, we have to discontinue the heparin immediately and give them an alternative drug to make sure that we can hopefully prevent any further clotting from occurring there. So there's a couple we'll talk about a little bit later on, things like leparudin or Gatraban. We'll talk about those in a few minutes. But you have to give an alternative, and then oftentimes we'll convert them over to something like Warfarin later on, hopefully prevent any further clotting that happens there. And we'll talk about low molecular weight heparins here. Someone who has HIT, you do not want to give them any kind of heparin-based product, okay? We'll talk about some exceptions there, but there is a cross-reactivity, and you do not want to attempt that. You don't want to tempt those fates. So moving into the low molecular weight heparins, this is where we're going to find that these are basically chopping up the heparin molecule into shorter fragments. You're going to find the activity changes a little bit. The biggest one you're going to see most commonly is called enoxaparin or Lovenox. Most of you probably heard of that at some point in your careers here. And so it's about a third of the size of the unfractionated heparin, still only given either subcutaneously or IV, so it cannot be given orally in these cases. But you're going to find the activity changes a little bit. So instead of working on 2, 10, 9, 11, and 12, you're going to find much more preferential activity against factor 10. It's a little bit of factor 2, but mostly it's going to be factor 10 is a big thing that's playing a role there. Okay. Still working factor 3, but because it's shorter, it can't really facilitate that binding with factor 2 quite so much. And so you end up seeing this ratio where you have about 2 to 4 times more activity against factor 10 compared to 2 versus unfractionated heparin, which is mainly 1-to-1 between those two there. Okay. Now this is important because the monitoring parameter we're going to use is going to change. We can't use APTT for low molecular weight heparins like enoxaparin because it doesn't measure well, right? It doesn't actually have a good correlation between the value and the actual anticoagulant effect we're going to get there. And you can kind of see this when you're looking at the binding. Notice here the molecule is shorter now, still working with antithrombin 3, so the mechanism is identical. You're going to find, though, that it binds very well to factor 10, not so well to factor 2. Maybe you can get a little bit of facilitation there, but it's not nearly as much as you would see with unfractionated heparin. Okay. So usually this one is really nice because you don't have to do as much monitoring. Usually it's just going to be based off of weight-based dosing, and a lot of times for most normal patients, I don't actually have to monitor anything. I don't have to monitor APTT regularly to see if it's actually working or not, which is nice. The thing we are going to use, though, is what we call anti-factor 10A. So it's a different lab value, and it's a little bit more expensive because it's newer, so a lot of places may be more hesitant to use it, but it's becoming more widespread nowadays. And so one of the big things to note here as well with enoxaparin, it is renally eliminated, so you have to adjust for renal function. So normally most patients I don't have to monitor for. So if I needed to give one of you guys, say heparin or Lovenox for prophylaxis of a DVT potentially, I wouldn't have to worry about measuring anything because again most of you would have normal healthy kidneys. I would assume healthy individuals. I could say okay, I just give you a weight-based dose, and I don't have to worry about it, right? Versus if I had someone who has poor renal function, or if I had someone who is in the extremes of weight, either very low weight or very high weight, pregnant patients, children, those are patients I'm going to be a little bit more cautious with, and I'm going to measure that anti-factor 10A. So for instance, in adult patients, you probably don't do a whole lot of 10A level monitoring, and like at Nemours, we do it for every single patient who's on Lovenox. Because again, we want to make sure they get in that right range, to make sure they're not going to be too anticoagulated, a risk for bleeding if it's too high, right? So we don't give them too anticoagulated. We don't want it too low to be at risk for clotting, right? So again, it's a double-edged sword. You have to walk that tightrope pretty narrowly there.
So basically, unfractionated heparin is when you're going to monitor their renal function because they're renally excluded, but not for enoxaparin.
So with unfractionated heparin, there could be some interplay with renal function, but it's not nearly as much. There's a lot more liver metabolism that goes on there. Enoxaparin, though, is much more exclusively eliminated through the kidneys, and so you do have to dose adjust and watch their renal function with that. Yep, for sure. Can still cause HIT potentially, but lesser risk. But again, if I had a patient who had HIT with heparin, I would not want to give them Lovenox. Okay, so just be aware of that. Now let's shorten up that molecule even further. Let's get it very, very short here. Now we have a drug called fondaparinux or Arixtra, and this is actually just the short pentasaccharide sequence. There's 5 sugar molecules long, and it only has factor 10 activity. No 2 activity, only 10. So how would I monitor for this? Anti-factor 10A, right? It's not going to have any real effect on APTT. So we're getting more specific as we're getting down to these shorter molecules here. Again, watch out in renal failure because, again, it's renally eliminated here. And the nice thing about this one, actually very, very low incidence of HIT. And in fact, some patients, some providers feel comfortable if they have a patient with a history of HIT to actually give them Arixtra or fondaparinux to actually feel comfortable with that because the cross-reactivity is very, very low in those cases there. So one thing you'll see. So moving on to a different category. So again, those are getting more progressively focused on factor 10. Let's focus on factor 2 for a little bit, right? So these are called the direct thrombin inhibitors. These are directly affecting factor 2. What's interesting, these are actually based off of the product called Hirudin. Anyone know where Hirudin actually comes from? From leeches. You remember like old-timey medicine, you think about people using leeches and sucking blood out of you. You know we still use leeches occasionally?
Yeah, I
There's medical grade leeches you can buy. We keep them in. We occasionally have them. I remember one time at a hospital I was rotating at, we had, for whatever reason, they needed leeches. And you have to keep them like, basically it's like an aquarium you have to keep them in, and they like to escape. So you'll find like leeches just crawling around the pharmacy wherever they're going to. They stink. So one of the technicians saw this big thing of leeches, and they're pretty expensive because, again, it's very specialized. These are medical leeches, not just your normal leeches you find out in the swamps. And so they're like, man, this thing really stinks. I think these things are going bad. I'm going to go ahead and toss them. So we went in and flushed them down the toilet. It cost like thousands of dollars. But yeah, so anyway, so let's just not use the leeches. Let's use the stuff in the leech spit, this uridine, they use as a natural anticoagulant and form some products based off of that. And so this is where we get things like leporudin, bivalirudin, and ergotraban. Now, these you can measure APTT because they're affecting factor 2 directly, and they're basically just going to bind these up and basically prevent any further activation of that clotting cascade. Now, again, most of these are renally eliminated, so you do have to watch for that. However, ergotraban would be the one kind of exception to that.
Antibiotic, whole grass fed.
They're only organic and free-range leeches. No, I think they're just grown specifically, so you're not just like picking them up out of the dirt. You know, they've been cultivated and, I don't know, pampered maybe. I don't know. There's something about them. They just whatever. They really suck though. Is all I'm saying. Okay.
Did they find those leeches? Did they have a tracker or something on them?
There's no tracker. There's like little collars you wear on them. No. Once they're gone, they're gone. You just hopefully don't find them on a patient later on that didn't need it, right? Okay. Anyway, so yeah, so the direct thrombin inhibitors, those are very good, especially if you have a patient with HIT. You can bridge them over to that and then have them on that, and that's going to help to bypass that effect there. Anyway, next one. This is a big one. This is called Warfarin, right? So this is nice because this is the first oral anticoagulant we've now talked about, okay? So Warfarin, anyone know what vitamin it works against? Vitamin K, right? Not potassium. I always have one student who will get that mixed up every single time. Vitamin K and potassium. Yeah, so again, it's easy mix up there. That's okay. So warfarin, actually this was found kind of by accident. And if anything, warfarin also is used as a rodenticide. Anyone know what a rodenticide means? Kills rodents, right? So we actually use this as rat poison still. We use offshoots of warfarin. So if you ever look at a rat poison in the store or something, it's called like brodifacoum. This is kind of the same family as warfarin here. So basically we're giving patients rat poison to anticoagulate them. Kind of interesting, right? Actually, warfarin actually gets its name from the Wisconsin Alumni Research Foundation, so sometimes you'll find kind of weird origin for drug names sometimes, but that's it. Coumadin is the brand name you'd see for warfarin most commonly. But basically, we discovered it many years ago, actually by accident, in some of the spoiled plants that these cows were eating. We noticed these cows were having these hemorrhages everywhere, and so they did some research to find out what it was, and actually they ended up getting warfarin. So basically what they find is that it's a racemic mixture, but actually the S enantiomer tends to be a lot more potent as an anticoagulant. That's going to be important for some of the drug interactions we'll talk about in a few minutes, because CYP interactions is going to be a big one for warfarin, as we'll see in a moment. So warfarin works as a vitamin K antagonist, okay? So very specifically, that's its mechanism and inhibits the activity of vitamin K. This will be important when we're talking about the antidote here in just a few minutes, okay? So basically what this does is it prevents the liver from forming vitamin K-dependent clotting factors. So the big ones that it's going to include is going to be 2, 7, 9, and 10. So again, 2 and 10 are going to be affected here. We also have 7 and 9 as well, okay? It also affects protein C and S, which actually have some anticoagulant activity on its own, which is an important factor I'll talk about in just a moment here. But basically, by preventing the recycling of vitamin K, you're going to be preventing it from forming new clotting factors. So if you think about it, with things like heparin, that was directly inactivating clotting factors. How fast do you think that worked? With heparin, like, it's directly inactivating the factors. It works very fast, right? It's helping antithrombin 3 work faster, very quick acting. Warfarin, though, it has to help block the production of clotting factors. How long do you think it takes to kick in? Several days, in fact, right? So again, I can't just give a patient warfarin starting it today and expect them to be anticoagulated before the next few days, right? I want to wait a few days before they actually develop the anticoagulation because they have to deplete themselves of the clotting factors they've already produced. Important point to note there, right? So that's when we talk about things like bridging therapy in a moment, that'll become important. Yeah, specifically, yeah. So basically what you're going to find is, anyone ever heard of bridge therapy before? What does that mean when I say bridge therapy? Yeah, you're continuing one drug while starting up another drug and then getting off the other one, right? The first one, okay? So we do that because, and especially patients you're bridging to warfarin, you need to have them on the heparin to keep them anticoagulated while you start up the warfarin. It'll take a few days. You're going to continue both in parallel. You may think, wait a second, this patient's going to be way too anticoagulated. Well, the warfarin's not even kicked in yet. So you do that for 2 or 3 days. Once they're, and we'll talk about the monitoring in a second, the INR is in range, then you can stop the heparin and they're good to go. So that's when we talk about bridge therapy. It's mainly because warfarin takes a while to kick in. Okay. So anyway, so again, just know vitamin K antagonist. That'll be really important for the antidote and the reversal agent we'll talk about in a moment. So again, just another picture kind of showing the same thing. Basically, by preventing vitamin K oxide reductase, you're preventing that recycling of vitamin K, and thus it cannot be used to produce new clotting factors. So again, very good at depleting these clotting factors here, but notice it has no onset or no effect on any already formed carboxylated clotting factors. Okay, so that means that delayed onset is very important there. And you can look at it to see how long some of these clotting factors take to deplete. So for instance, things like factor 2 has a half-life of over 60 hours. You can see why it takes a while to deplete that's already been formed before you really see the anticoagulant effects. However, the big thing you're going to notice initially is that especially with protein C working as an anticoagulant, that gets depleted first. Well, if I deplete myself of an anticoagulant, what can occur? Coagulation, right? So again, that's actually what you find is when you start patients on warfarin initially, they can become hypercoagulable, which is again why bridge therapy is so important. By having the heparin on board, you can prevent and head off that procoagulation aspect of warfarin before it really kicks in and has the anticoagulant effect. And it's getting confusing. We kind of think about it based on the fact that, you know, what's going to be a procoagulant, what's an anticoagulant, et cetera. You'll see how that kind of works out from a time standpoint. Anyway, as I mentioned, antithrombotic effect within 5 to 7 days. That's when it's going to be kicking in and having the best therapeutic effect. So this is nice because it's given orally, and so for a good long time, many decades, this is the only oral anticoagulant we had, and it's but just rife with drug interactions, right? So one of the big ones is because it's highly protein bound to albumin. So that means if I have something else come along and kick it off of albumin, guess what happens? Concentration is going to go up. They're going to have more vitamin K being inhibited. Guess what? More bleeding. Okay. So again, that's a big deal. Also, looking at this, we see that the S enantiomer, which I mentioned is more active, is inhibited or is metabolized by CYP2C9. If I had something come along and inhibit CYP2C9, guess what's going to happen? Warfarin levels are going to go up, and they're being more likely to bleed. Okay. Now, the R enantiomer has some 3A4 activity here, but it's going to be less clinically relevant than the actual S enantiomer, so just be aware of that. This one you cannot use in pregnancy, which is kind of unfortunate because if you have a hypercoagulable pregnant patient, you have to give them something injectable most of the time. So again, that would be avoided for most of those patients there. So drug interactions. So let's look at the activity here. So how could I directly affect the activity of warfarin? We know it inhibits vitamin K, the recycling of it. But what if I give the patient more vitamin K? What's that going to do? Well, it doesn't decrease the warfarin levels. What does it do? It gives me more vitamin K so that I can make more clotting factors. Okay, so vitamin K intake does not directly affect warfarin levels, but it affects how many clotting factors I can produce, right? Because it doesn't affect the initial vitamin K from being utilized. It prevents it from being recycled and reusing that vitamin K. Okay, so that means that this is entirely diet dependent. Okay, now where do you get vitamin K in your food from? Green leafy vegetables. Now, my first rotation I ever did was in a community health center in Palatka, Florida, Putnam County. Guess what those people like to eat? Collard greens, kale, spinach. Like, they love these foods. They grew it themselves. These are the salt of the earth kind of individuals, okay? So anyway, so the big problem with them is that we had to monitor their warfarin. Like, a lot of these patients need to be on warfarin for AFib and things like that. But the issue is that their diets could be really dependent. You know, a lot of them were pretty poor too, right? So again, their access to food changed over time as well. So there could be times where they had a lot of food and they're getting a lot of greens in, and then sometimes where they weren't. And so that would directly affect how well they would be anticoagulated, either too much or too little, and affect whether or not we need to adjust their dose. So a lot of monitoring goes in with warfarin. This is why it was such a hassle for a good long time, is because people had to constantly kind of come back in to have their levels rechecked. Okay, so just know that more vitamin K intake is going to cause your levels, or and again, when we talk about monitoring, we'll talk about INR as being the monitoring parameter we're going to use there. It's going to cause INR to go down, right? So just like we saw with APTT, when the level's higher, that means it's taking longer for the blood to clot. That means you're getting more anticoagulant effect. Same thing with INR. The level's going to go up as you get harder and harder to clot that blood, okay? So if you have people who are intaking a lot of vitamin K through their diet, you're going to find the INR is going to go down. It's going to get closer to the baseline level, which means you're not very well anticoagulated. You're more at risk to have a clot, right? What's a big issue with AFib and clotting? So yeah, it did develop stroke, right? Because again, you have that kind of that quivering atria, and it's going to have that stasis there. You're going to have a little clot that forms and then can get thrown in and cause a stroke. So a lot of those patients happen to be AFib patients we were treating with warfarin there, but you'll see use for other indications additionally. So that's a big thing to note, right? Vitamin K intake is super, super important. Okay, it's good to know if I have increased vitamin K intake, what's that do to my INR? If I have low vitamin K intake, what's it going to do to my INR? go up, right? And so does that mean patients should never eat any green leafy vegetables? No, they're good for you, right? The issue is you got to stay consistent with it, right? So you don't want to have a patient who says, I'm going to go on a 3 spinach salad a day diet for the next week, and then they crash and burn on that diet, and then they switch over to something else. So they get no vitamin K. Those patients' INRs are going to go all over the place, right? They need to be consistent about it. So that's a big thing, a big education point. Anyway, things will increase the effects here. If you have CYP2C9 inhibition, it's going to cause levels to go up of warfarin, and that's going to cause it to be more effective at inhibiting vitamin K. Thus, you're going to have less clotting factors produce it, right? And things that are affecting the protein binding, anything kicking it off of albumin, it's going to have a higher free fraction of drug. It's going to be more active, right? Another big thing to consider here as well is where do we get a lot of our vitamin K from? We said from the diet, but specifically the gut bacteria are really important for helping to process that vitamin K so that we can absorb it. So one of the big interactions you're going to find is that if you have things like antibiotics come through and clear out that gut biome, you're going to find you have less vitamin K being absorbed. You're going to find that affects your INR as well. So typically when patients go on antibiotics and are also on warfarin, you have to adjust their dose down. Okay. Now if you remember back to when we talked about antibiotics, anyone remember which one inhibits CYP2C9? Bactrim, yeah, very good. So Bactrim inhibits CYP2C9. That will cause warfarin levels to jump up. It will cause levels to jump up and also cause the INR to jump up very significantly as well. Not only by inhibiting the levels or inhibiting the metabolism of warfarin, but also by inhibiting that vitamin K intake by affecting the gut biome, right? So that's a big interaction you have to worry about is Bactrim and warfarin. INRs can spike pretty high there. Anyway, if you have liver dysfunction, you're not producing enough clotting factors anyway. And again, what can you monitor with patients who have very severe liver dysfunction? AST, ALT for sure, but how do you actually tell the actual function of the liver? PT-INR, because you want to look to see how well it's functioning to actually produce, because it's kind of a misnomer. Liver function tests like ALT and AST actually don't tell you how much functioning is happening with the liver, just tells you how much damage is kind of happening to it. You're spilling out those enzymes. The INR tells you the function, right? Because if you're not producing clotting factors, your liver's not functioning. So that's, again, one thing we'll see a lot in patients with very severe hepatic injury. But if you already have severe hepatic damage, guess what? You're not going to be able to produce those clotting factors. You're going to see increased effect from warfarin. And the elderly tend to be a little bit more susceptible to this anyway. So we monitor with PT-INR. Now, PT can range from lab to lab. We're going to measure it at, but the way that they've worked to try and standardize it is by using this INR. Anyone know what INR stands for? International Normalized Ratio. Okay, so basically, and you don't have to really know what that means. Just know the INR is the way that we can kind of compare apples to apples between labs and labs, right? So that way, if I go and get my INR done here at Florida Hospital, and then I go and do it at Nemours, and I do it at ORMC, they're all going to be the same value essentially, right? That's how we modify these. Now, the target INR we should get to. Now, again, this is a ratio, which means that my denominator is going to be normal clotting blood, right? It's going to be a normal healthy patient, right? Versus my level, my PT, that's going to be higher than now that I'm on warfarin, okay? So that means that what is a normal INR for any individual sitting in this room who presumably is not on warfarin? 1, right? Not 0, it's 1. So a normal INR is 1, right? Because again, it's a ratio between the two, okay? So anyway, so when I have someone who's on warfarin, that ratio is going to go up. My numerator is going up. So that means that level should go up. So again, when you see APTT, normally that's measured in seconds. This isn't going to be unitless, right? Because the units cancel out here. So basically an INR for normal individual healthy patients, or I guess not a healthy patient, but a patient who needs to be on warfarin should be at a ratio of 2 to 3. It's a very good number to know. So patients on warfarin should be 2 to 3. That is a therapeutic INR. There are some cases where you may need extra anticoagulation, especially if they're very high risk for coagulation, specifically when you have things like mechanical heart valves, right? Because again, anytime you introduce foreign products into a patient, that can be a site for infection, can be a site for clotting. Mechanical heart valves require 2.5 to 3.5. Okay, but for majority of patients, 2 to 3 is a therapeutic INR. So when you see an INR of 5 or 6 or 7, that's when you should start to worry, because that means their risk for bleeding, okay? So you got to be really careful when you start to see INRs creep up like that, okay? Anyway, so again, as I mentioned, if you have mechanical heart valves, that's usually the biggest reason why you may need to have that shoot for that higher INR, but 2 to 3 is fine for the majority of patients there. Now, and again, be careful because there's pharmacogenetic influences here as well, because some patients have poor functioning 2C9. That poor functioning 2C9, guess what happens? Levels are going to go up because they don't have as many of the enzyme to actually metabolize that warfarin. Okay, so again, some patients are going to be more sensitive than others. And you're thinking like, why the heck do we use warfarin? This stuff looks so complicated. You have to worry about the diet, you have to worry about their genetics, you have to worry about all these drug interactions. But that's all we had for a good long time, right? Because again, you didn't want to use parenteral therapy for these patients who are going to be on it for decades, but that's all we had. So, and again, looking at bleeding, you're going to find that the risk is going to be higher the INR gets. So again, looking at this, as soon as INR gets above 4, that's when you start thinking about risk for things like intracranial hemorrhage. Obviously, the higher it is, the more likely that is to occur. And so we need to know what the reversal agent is. Reversal agent for warfarin is going to be. So a couple options, and I've already heard both of them, right? So again, in this case here, how do I want to reestablish normal production of clotting factors? Give them vitamin K, right? So just like if you don't give them like a bolus of spinach or something, but you give them IV or PO vitamin K, and it's going to do the same thing as if I were to increase it through diet alone, right? I'm increasing the vitamin K intake, that's going to cause the levels of clotting factors to start to go up because I'm now producing more of them, okay? That's one way to do it. But that takes time, right? Because it takes time to produce the clotting factors. If I need to fix that patient's bleeding right now, what do I give? Fresh frozen plasma, right? Because that's going to include all of our clotting factors in it. And that's good because when I give that, you're going to find that that will then replenish the body of the clotting factors. They can then start to clot again, okay? So that is the fastest way to do it. If I have a patient who's maybe at risk for bleeding, isn't bleeding yet, give them some vitamin K. That'll be fine, right? But if they're having an active bleed, if I check that CT scan, I see, and again, if the pharmacist can tell there's a bad head bleed, it's a bad head bleed, right? So again, when I can see that, I'm like, oh, yeah, that patient needs some FFP right this second, otherwise they're going to die, right? So again, you got to be careful with this stuff. Again, other things you may find, birth defects. We mentioned steroidogenics. You do not use this in pregnant patients. And then one thing you'll see kind of over time with these patients, they'll develop kind of these little skin bits of skin necrosis over time. That's usually due to protein C or S deficiencies induced by the warfarin there. So I mentioned, warfarin therapy was so complicated, it was so hard to deal with for a lot of patients. That's all we had. Nowadays, we have the new oral anticoagulants. If you ever hear of NOAC, that is what we're talking about here, okay? So these are oral agents we now have that we can use to help anticoagulate our patients. You're going to find these mitigate a lot of the food interactions. You mitigate a lot of the drug interactions. These are much easier to monitor for. But we'll talk about some drawbacks for them in just a moment here. So the three big ones we're going to talk about here. There's some other new ones that have come out recently, but these are probably the most common ones. You have things like Dabigatran or Pradaxa. You have Rivaroxaban, Xarelto, and then we have Apixaban. Okay. Now, the one thing I will show, one thing to kind of help with the naming convention here, because again, they're going to have a couple different mechanisms. If there's an X in the name here, what factors do you think it works against? 10, right? Got your Roman numerals. So again, think Rivaroxaban and Apixaban. Those are going to be factor 10 inhibitors. We'll find that Dabigatran is actually a factor 2 inhibitor. Okay. So anyway, so these are oral agents. Direct. First one is Dabigatran, which is a direct thrombin inhibitor. So thrombin's factor 2, right? So again, by inhibiting factor 2, you're going to inhibit that kind of feedback loop and prevent other factors from being activated as well. Same indications as you would use it for warfarin. And again, this one, how long do you think it takes to kick in? It's quick because it's a direct thrombin inhibitor. It'll go and directly inhibit that factor 2. So you're going to have much faster onset than you would see for something like warfarin, okay? Because again, the mechanism is different. And again, the biggest risk is going to be bleeding, right? There's no monitoring associated with this because again, we don't have a good level to tell us, okay, how anticoagulated they are, too much, too little. So again, that is one thing that patients don't have to come back in and get monitored all the time. That can be good from from a compliance standpoint. They don't have to keep coming back in to see you. However, though, you may go longer before you realize there's an actual problem going on there. The other problem is there's no good reversal agent for this drug. Okay. I say there's no good one. There is one, but there's no good one. So the problem with this is that let's see if I have it on here. I didn't include it, but there is a monoclonal antibody that the company that produced the Dabigatran is now making that will then go and bind it up, basically, right? And so again, not everywhere is going to have that. It's going to be very expensive. And so again, if you have, say for instance, a head bleed due to Dabigatran and going to the ER, it's going to be, who knows if you actually had the factors or the antibody there to actually treat it. However, if I have someone who's having a head bleed from warfarin, guess what? Everyone's got vitamin K. Everyone's got FFP. So the reversibility can be a big factor there. So you have to think about your patients. If I have, say, an 84-year-old little lady who is at risk for falling, hitting her head in the bathtub, that may not be a great patient for something like Dabigatran, right? Because I can't reverse that very well. Versus someone who is on warfarin, I can reverse that very easily. So again, from a patient safety standpoint, you have to kind of think about the pluses and minuses there. Now, if I have a young lady who's a smoker or was on birth control and get the DVT, they're probably not a big risk for having things like a fall and whatnot. That's probably a better patient that could be on something like Rivaroxaban or Dabigatran, right? So think about the patients, think about the risk of this kind of ancillary bleeding effects. Anyway, next we have Rivaroxaban, which is a Xarelto. This is a 10A inhibitor. Again, used for similar indications, DVT AFib, PE, all those. And actually, there are some protocols now where a patient who comes in with a diagnosed DVT or PE, they can actually be started on one of these drugs right there in the ER, and they never have to be bridged over to Warfarin or heparin or anything like that. So it's actually some of the new changes you're going to find out there. So it's kind of interesting because now you can just say, hey, go to the ER for DVT, and you just get a pill to take, and now I'm anticoagulated. So it's kind of cool from that perspective. But now again, here you're going to find that FFP won't be very good at reversing the effects here, but they do have what we call a prothrombin complex concentrate. That's basically a very concentrated form of a lot of clotting factors that can sometimes reverse the effects, but again, it's not going to be as reliable as something like vitamin K would be for warfarin there. Okay. And you have Apixaban, very similar acting as we would see with the Rivaroxaban. Again, it's just kind of like a me too drug. So again, it's one of those things where we have an alternative to warfarin. This is great. Let's produce a bunch of different drugs that are going to do the same thing essentially, just like the ACE inhibitors, just like the ARBs, just like we've seen with statins, etc. One thing to note with the Apixaban though is metabolized by 3A4. So if you have an inhibitor on board, you do have to watch out for those drug interactions. Okay. Okay. So now let's talk about how we're going to use some of these anticoagulants for treatment of, say, acute coronary syndrome. Now, I say acute coronary syndrome, what am I referring to? STEMI, InSTEMI, also unstable angina. Good. All right, so those are the three big kind of delineations we're going to be talking about here. Now, when we have a clot like this, what do we need to do to it? We want to get rid of it, right? We're going to bust that clot. At least we're going to talk about it from the drug perspective here, right? So there's a couple different options here, but we're going to focus on. And kind of what's the most severe one we're looking at? STEMIs obviously going to have the most blockage occurring there, right? So again, it's going to be the most severe. We're going to find that the therapy differs a little bit between the STEMIs versus, say, non-STEMI, right? So therapies will be a little different between that. And when I say unstable angina, what does that mean? So, yeah, symptoms at rest, right? So again, if I have stable angina, I can have some exercise tolerance before I develop chest pain symptoms, but these patients are having at rest. So anyway, so what's happening here with a lot of these thrombus formation here, normally you have this plaque that will be developing. Some of it's going to be occluding blood flow through there. But we can actually have either a spontaneous rupture, or for instance, if I were to say deploy a balloon there, during PCI, you can see this can damage that vessel, and it's going to cause that plaque to open up. Okay. Now, when that does happen, you're going to find you're going to have things like platelet aggregation occurring here. So, what kind of drugs do you think we're going to use for that? Aspirin, clopidogrel, right? So again, all the stuff is kind of coming back, and how we're going to use these here, right? And then we have a bunch of fibrin forming. How are we going to treat that fibrin? We can use fibrinolytics, so actually directly actually degrade the fibrin. What else could I use? Maybe to prevent the fibrin from being formed. What forms fibrin? Factor 2, thrombin. Thrombin forms the fibrin that causes that activation of fibrinogen over into fibrin. So if I give something that inhibits factor 2, heparin, enoxaparin, what else? Pradaxa could do it potentially, or argatroban, lepirudin, any of those could be potentially inhibiting that process, right? I could even give something that worked on factor 10, and that will then secondarily affect factor 2 as well, right? So again, there's lots of different options here. So you're going to use antiplatelets, you're going to have anticoagulants, and then we'll also talk about the fibrinolytics. That'll be kind of the new class of drugs we'll talk about in just a moment here. Again, this is where we have that occlusive thrombus. That we're going to see a lot of that pain coming from, that chest pain. We're going to see a lot of the ischemia and infarction happen there. Okay, so again, looking at this process here, we can see things like thromboxane A2, ADP. We've already talked about these as being targets for antiplatelet drugs, right? What affected ADP? Things like clopidogrel, prasugrel. Yeah, P2Y12 inhibitor, yeah, basically. Thromboxane A2, how can we affect that? Aspirin was one of the big things that affects that, right? Absolutely. So we can affect platelet aggregation by affecting those, right? The clotting cascade, things that are affecting thrombin. We've already seen just now a bunch of drugs that affect that as well. So again, we're going to be working kind of on both sides of the pathway here because, again, it is a positive feedback loop. I want to interrupt that in both senses so that way I can hopefully prevent this thrombus from getting any worse. Hopefully try to open it up a little bit, okay? So the goals here, we want to reestablish that coronary flow. We want to relieve that chest pain that the patient will be experiencing there. And hopefully, if it's not progressed to an MI already, we can hopefully prevent that progression, okay? And then obviously, it's the secondary effects you worry about after having that infarct and that ischemia, things like development of CHF, further MIs that can develop down the road, hopefully preventing death, right? That's always the main goal. So looking at this, we're going to find the common drugs. And what's the acronym used for a patient who has chest pain? What do you have to be? Beta, okay, yeah, so we'll talk about that. I always hear MONA. That's always the thing I always heard of. And MONA's kind of changing a little bit. You're going to find that may not be always the case there, right? So MONA stands for what? Morphine, oxygen, nitrates, and aspirin. Aspirin, right, is A.
That's not mono.
It's not mono, it's MONA. So anyway, so let's look at the drugs you're going to be using there, right? So, okay, so we have, first off, aspirin should be one of the first things the patient will take when they have that acute chest pain, right? So again, how much should they take? Actually, I like 324 because what do we usually tell them to take?
4 baby.
4 baby aspirin, so 81 times 4. Again, it's a minor point there, but whatever. 324, 325, whatever. But again, 4 baby aspirin, have them chew that up. And again, it's going to help with the dissolution and the absorption of the drug a little bit faster there, okay? We know that decreases mortality and reinfarction rates because you're inhibiting those platelets from aggregating due to that thromboxane, okay? Even if they take a baby aspirin every day, have them take that 324, 325, whatever pleases you. Now, if they're having chest pain, this is where nitrates are going to be coming into play here. This is only used for symptom management, okay? And again, how often do you tell them to take those nitrates? Every 5 minutes. We already talked about angina, right? Right, so every 5 minutes. And again, when do they call EMS? If the first dose does not deal with the chest pain, then they need to call EMS, right? Because time is tissue with these patients here. Good. And beta blockers. Now, beta blockers should be initiated for these patients. It's very important because we know it decreases mortality. However, who might not be a good patient or a good candidate for a beta blocker? When we're talking about an acute chest pain, this patient's progressing towards a heart attack if they're not having one already. Bradycardia, heart block. Yeah. So for instance, if they're hypotensive, they're not perfusing. Like these are patients you don't want to give a beta blocker to because you're going to make their situation worse. But if they're coming in, they're tachycardic, they're super, agitated because they're having this pain and they're having a lot of anxiety and they're hypertensive. That's a great patient for a beta blocker. Go ahead and give it to them. It's going to chill them out a little bit. It's going to help with the heart rate, the blood pressure. It's going to help out with a lot of those factors there. That's a good patient for it. So you want to give them on a beta blocker as soon as you can. But again, if they're acutely decompensated, they're hypotensive, bradycardic, do not give them a beta blocker. Okay, you're just going to make their situation worse. So again, who might not be a good candidate for aspirin? Obviously, they have allergy, if they have recent GI bleed, anything like that. You want to be careful with that. And again, we've talked about these agents already, so I'm not going to belabor these points here. Okay. Nitrates we mentioned, start with sublingual therapy until you can get more definitive care when EMS arrives. Maybe you'll start up an IV. Now again, nitrates are going to do what to your blood pressure? Typically decrease it, right? So if a patient's hypotensive, do I want to give them nitroglycerin IV? No, typically you don't want to do that. What other would be an indication would I not want to use nitroglycerin for? What type of MI? Yeah, so you worry about a right-sided MI because, again, you worry about the preload issues, you worry about causing hypotension. However, that doesn't really apply to the oral stuff. And as I mentioned, when EMS is arriving, do they know if you have a right-sided MI or left-sided? No, they're just going to give you nitro anyway, right? So, again, it more applies to the IV formulation, okay? Again, if they were on what type of drug would they be contraindicated from receiving? Viagra, Cialis, Levitra, any of those phosphodiesterase inhibitors, do you want to give it to them because what could happen? Hypotension, right? Good, fantastic. Now, again, no necessary mortality benefits, but very good for helping to manage that pain. But if nitrates aren't good enough to handle that pain, what else could we give them? What's the M in Mona? Morphine. That's where we can do morphine. So we'll talk about that in a second. Beta blockers, as I mentioned, start off with IV. You can transition over to PO kind of once the patient's kind of stabilized to a point there. But again, watch out if they're bradycardic, hypotensive. Now, morphine. This is a newer drug we haven't really talked about before. I thought it was a very funny picture. But now, how does morphine work? Morphine is an opioid agonist, right? So again, we'll talk about pain meds next semester, but we'll talk about this here because it's particular in use for acute coronary syndromes. Now, is there anything magical about morphine? No, I mean, some people might find it magical, but any opioid would work here. We're just using this for the pain relief, okay? So there's no necessary increases in outcomes. There's no decreases in mortality seen with this. It's just to help with the pain aspect for these patients. So if they were allergic to morphine, there are all alternatives you can give. There's nothing special about morphine specifically, okay? We'll talk about that more later in next semester, but very good for the chest pain here. Some people may even feel it may increase mortality in some cases. So you do want to be careful with that. However, morphine, probably one of the more common ones usually patients have an allergy to, so you need to ask about that. And also, morphine causes a lot of histamine release, which means you can see hypotension from that. So if the patient's already hypotensive, morphine again may exacerbate that, okay? All right, so let's look at the drugs we can actually use to help work on the clotting cascade in regards to acute coronary syndromes, right? So we mentioned antithrombin 3 is going to be playing a big role here. We're also going to be finding a couple other factors going to be important here as well. But the new class of drugs we're going to talk about are going to be the fibrinolytics, okay? When I say fibrinolytics, what does that mean? Lysis fibrin, right? So again, it's going to be able to take that already stable fibrin that's formed and try to basically inactivate it, okay? So we're going to find there's a couple different factors that are involved with that. So basically, we have plasminogen. That needs to get converted over into plasmin. So most of the drugs we're going to be focusing on as a fibrinolytic is helping to convert that plasminogen over to plasmin. Plasmin then goes and inactivates fibrin. Okay, and so that's where you're going to find things like tissue plasminogen activator. It's right there in the name. Plasminogen activator is going to be really helpful here. So TPA is going to be playing a big role here, and this helps to lyse that fibrin. Also can work on several other factors like thrombin, work on factor 5, 7. So again, it has kind of a multi-use when it comes to that aspect. So I'll show you a picture, kind of shows you where different ones are working here. And again, depending on where you work, you may find you're using one versus another more commonly. I'll tell you fibrinolytics are not just used for acute coronary syndromes. What else might you use it for? For stroke, yeah, ischemic stroke specifically, right? And what else? Yeah, like massive PE, you know, patients decompensated. Those are the big ones, right? Whenever you have a life-threatening clot, this is where you're using these fibrinolytics, right? Because again, what's the main side effect from these drugs going to be? Bleeding, right? Really bad bleeding, like you're going to kill the patient kind of bleeding. So you have to be really, really careful with these drugs. You have to make sure that the patient meets specific criteria, because otherwise, if they're too high risk for bleeding, you just can't use it, right? So you got to be really careful. And that's why a lot of times, especially in the case of acute coronary syndrome, we're not using a lot of these fibrinolytics anymore. We're moving more towards revascularization. We're moving more towards getting into the cath lab. But again, if you're in the middle of the Podunk Panhandle of Florida, and you don't have already access to a cath lab, you may have to use one of these fibrinolytics. So it's good to at least know what they're used for. We see these a lot for ischemic strokes as well, so you at least want to be somewhat comfortable with them. Anyways, this is the big thing we're focusing on. Now, if you're looking, different drugs are going to work on different aspects here. We'll have things like streptokinase kind of working here on some of these plasminogen activating complexes. Some of them are going to be working directly to cause that conversion from plasminogen over to plasmin. Just know that at the end of the day, what they're doing is converting that plasminogen to plasmin. Plasmin breaks down fibrin. Okay, that's all we need to really know about those. So, a couple of ones we're going to talk about most commonly are going to be the tissue plasminogen activator, TPA. We're going to talk about redoplase and the tenecteplase. These other two, streptokinase and urokinase, either are not used too much in the U.S. or they're used outside of the U.S. So I'm not going to really focus on those too much. But again, very similar responses, very similar adverse effects with these. And the main thing being bleeding. It's one you want to be really careful with. So as I mentioned, bleeding, these are oftentimes protein-based products as well, so you do have to worry about allergic reactions. And sometimes you want to worry about patients getting a second round of these drugs. They may have a sensitization, may have a secondary reaction to that. And then also we can see some ventricular arrhythmias. However, a patient having a heart attack is already at risk for ventricular arrhythmias. So again, sometimes it's hard to tell if it's a chicken or egg sort of phenomenon there. So looking at this, there's a big long list of contraindications you have to think about, right? So again, timing is really important for these drugs, especially when you're looking at things like ischemic stroke, but also look at the contraindications. And so you have to go down this list, because again, if you miss one of these and give it to a patient and they bleed out and die, guess what? That's on you. So you don't want to do that. So little things like think about, you know, when have they last had surgery or organ biopsy or anything like that. So again, time frames can be really important here. So again, within 10 days. Okay, you don't want to give a fibrinolytic in those cases, right? Then again, these are absolute contraindications. Gastrointestinal bleeding within 3 months. History of hypertension with a diastolic pressure than 110, greater than 110. It's not uncommon to see in some of these patients. It may sound really, really high, but that's some of these patients you're going to run into, right? Now, does that mean I can't give it ever to those patients? No, sometimes I can give them antihypertensives. I can give them something like labetalol or hydralazine or something to try to get their pressures down. And if you do successfully get the pressures down, then they may be a candidate. So that's something you can try, but normally if you have a diastolic greater than 110, don't want to give the fibrinolytic. Okay, any kind of active bleeding disorder, any kind of previous cerebral vascular accident, again, you know, there's a bigger risk there. Like tumors.
Question.
Yeah.
So you said we could give them in that circumstance hydralazine.
Yeah.
But so because I thought hydralazine was contraindicated in coronary artery disease, ischemia, and elderly. Use that, or is it just that's like a relative contraindication? It's
probably a relative contraindication. I mean, if you need to get the pressure down, you need the pressure down. So there's a lot of ways to skin that cat. I just said hydralazine as an example, but you might want to use something more as a continuous infusion to try to help better regulate the blood pressure. You know, hydralazine is more of an intermittent kind of drug, but if I want to use like esmolol or nicardipine or anything like that, I could try to use to try to get that under control. But imagine, you know, we mentioned Mona B, the beta blockers. If a patient is hypertensive and I'm trying to get their pressures down to give them the fibrinolytic, maybe something like a beta blocker like esmolol could be a good option for that patient, you know. So you have to take into account based on specifics with your patients there. But I'm not aware of any specific contraindication saying that you absolutely could not give hydralazine, especially if the pressures are that high.
Yeah, I just remember it being in the notes. I thought it was
yeah, it probably is more of a relative contraindication. Like a beta blocker might be a good option to go with in those cases too. Yeah. Anyway, right, so any aortic dissection. So just be kind of aware of those. That these are the things that if you meet any of these, you do not want to give these drugs here. The bleeding risk is just too high. So the three big ones you're going to run into will be alteplase, or TPA is another name for that. Basically, it's going to be a recombinant formulation of a normal TPA that our body produces anyway. Again, I don't know how they organize Chinese hamster ovary cells to produce these, but again, I don't work in those labs, so I don't decide what kind of cells they use there. But it's probably something about them makes them really good at making TPA. But again, very expensive drug. Now, I'll tell you, the more common place I'm going to see TPA actually being used is not necessarily for clots that are more systemic, but where else might I see a clot that I want to treat? And STEMI, yeah, so you may use it for that. You guys can't read my mind, so it's a bad way to ask a question. But basically for catheter-related occlusions. Yeah, so a central line, or if I have a port placed or anything like that, those can clot off, especially if they're not being heparinized well, things like that. Usually heparin is left in the line to make sure that it does not clot off, or any blood that kind of gets caught in the line there. So oftentimes when those get clotted off, we will give TPA to actually bust that up. So if you ever hear of cath flow, that's what we're talking about. It's basically TPA. It's a small dose of cath flow of TPA that you're giving into that line to try to bust up that clot, so that way you can get a better flowing line again. Because for some patients, getting a central line replaced can be a pretty harrowing sort of thing there. It can be very difficult, especially if it's an implanted port or something like that. So you want to save those lines as best you can for your patients. Okay. You have Retiplace as well, Tenectoplace. Now just note they have different sources where they're coming from. So again, that may change, how likely the likelihood of someone having an allergic reaction to it. But again, they're all going to be working pretty similarly to one another. And again, a lot of times this is not the main drug you're going to go to. It's to get them to the cath lab. It's kind of the more important thing in most patients. So, as I mentioned, time is tissue in these cases here. So you want to look at the age of the patient. You want to look at the time of onset of symptoms. So again, if they're over 75, they're just too old. They're just going to be too high a risk of bleeding there. So usually you will avoid that. If it's been too long of a period of time, if it's been greater than 6 hours, or if you have an in-STEMI, there's no evidence to show that it's going to be that much beneficial, so we avoid it in those cases there. And again, bleeding between 0.5 and 7% risk, but notice this intracranial hemorrhage between 0.4 and 0.94. That's almost 1% risk. That means every 100 patients you gave that to, almost one of those would have intracranial hemorrhage, right? And again, if they're coming for a heart attack, you don't want to give them intracranial hemorrhage. It's no good. So again, very risky. However, if they meet the indications, they can use it safely as needed, right? Okay, other agents you might use in acute coronary syndromes are 2B3A inhibitors. Anyone remember any options there? Apixaban's a good one. Apixaban. Ticagrelor was actually an ADP. Right, ticagrelor is actually a ADP receptor antagonist, right? Yeah, but Rivaroxaban is probably one of the big ones you'll see there. Apixaban for sure, but yeah, those are 2B3A inhibitors. Oftentimes, depending on the situation, you may not use this with STEMI necessarily, but you can see these used prior to PCI. ADP receptor antagonists are going to use pretty frequently, so ticagrelor, prasugrel, clopidogrel, fine there. And then most of the time, the heparins are going to be used in conjunction with fibrinolysis. Again, that makes sense because again, if we're using with antiplatelets or fibrinolysis, this is working on the clotting cascade. Antiplatelet drugs are working on the platelet pathway, and you have the fibrinolytic working directly on that fibrin that's already formed, right? So this is helping to prevent new fibrin from actually being formed by inhibiting that process. All right, to give you an idea, sometimes patients will need to be on long-term antiplatelet therapy depending on what's going on. So again, if they were to have, say, a stent being placed here, as I mentioned, anytime you have foreign material, what likes to bind to that? Platelets, fibrin, right? So again, we have to sometimes we'll give antiplatelet products long term to try to keep the stent from clotting off, right? And especially if you have like a drug-eluting stent that will try to, that has a different risk associated with it, so the time frame will change depending on how many months you have to give antiplatelet drugs for in those periods there. Usually something like an ADP receptor antagonist is given most frequently. But looking over at, in STEMI, looking at unstable angina and MI, you're going to find that the therapies are pretty similar, except you really don't use fibrinolytics for these patients. Most of the time, again, get them to the cath lab is the most important thing. And most often, they're going to be using 2B3A inhibitors more commonly, and then enoxaparin gets used a little bit more frequently than heparin. Really only big differences in those cases. So that's it for cardio part 3. Any questions on that? That's a bit of a whirlwind, but again, very important drugs you're going to run into. Okay. All right, so let's do a 10-minute break. We'll come back and then continue on. Questions from the first half. All right, so moving on. Again, this is going to be another section. It's going to be a lot of the same drugs. We're just talking about how we're using them a little differently here, right? So the first thing, focusing on CHF. Have you covered this in Clin Med yet? Fantastic. Good job. All right. So again, why do most people get CHF? MI, chronic hypertension, there's other things you could have, certain drug-induced sorts of cardiomyopathies. There's actually a particular cancer drug we'll talk about at some point that actually causes cardiomyopathy, can lead to CHF. So there's lots of different reasons for it. But what's the kind of the main problem? See, yeah, the contraction, especially, and again, there's left side or right side of heart failure. I'm mainly going to focus on the left side thing here, is that you're going to have decreased contractility of the heart. The cardiac output's going to go down. That ejection fraction typically is going to be reduced, right? So that could be due to things like the left ventricle getting more hypertrophy, right? That sounds like a good thing, right? More muscle should be able to pump better, right? Why not? Less blood can actually fit into the space, right? You're going to find that the left ventricles will become thicker, it's going to become less compliant, can't really fill as well, and so you're going to find that it becomes less efficient over time, right? And so you're going to again look at it as that a reduced ejection fraction is the most common thing you're going to be seeing with that. So with the diastolic dysfunction, a lot of it goes back to impaired relaxation, right? So some of it has to do with that left ventricular hypertrophy causing it to be a lot thicker. In some cases, ischemia can affect this as well due to impaired ability to recycle calcium effectively. We know calcium is really important for causing that binding of the actin and the myosin. But again, we have decreased filling, so you're going to have decreased cardiac output due to that as well. Okay. And so looking at the compensatory response, if we can't get enough blood coming out of the heart, what can we do to fix that? Yeah, so we're going to modify the blood pressure, so we can try to increase vasoconstriction, right? How do we manage that? Alpha constriction, what else? Angiotensin too, right? Renin-angiotensin system is going to be playing a big role here as well, right? We can increase the preload. We can try to hold on to more fluid, right? What happens to all that fluid eventually? Yeah, it can only handle so much of that preload. It's going to eventually leak out into places like the extremities. Where else can it be particularly dangerous? The lungs as well, right? You can get pulmonary edema from that, like pulmonary congestion, right? We're going to see a lot of tachycardia and trying to increase contractility by increasing sympathetic effects on the heart. And again, all that's going to just continue to worsen. It's kind of the sick cycle where basically the things we're doing to compensate are going to make the problem worse overall. Okay, so we have to interrupt the cycle to try to make sure that we're going to have preserved function. Because again, can we reverse this hypertrophy and this damage done to the heart? You're going to find you cannot reverse it necessarily, but hopefully we can prevent progression of that disease. Okay. Anyway, looking at it, looking at common precipitants of decompensations. When I say decompensation, what do I mean? Kind of an acute decrease in function, right? So the patient may be kind of trucking along very well on their own, right? There's going to be some exercise compliance issues. They may not be able to get around quite so well, but usually something will happen where they may get off of their meds, or maybe their diet changes, where they're taking on a bunch of salt and fluid all of a sudden. Maybe they have an arrhythmia. Anything like this can happen where they have an acute decompensation, where they can have increase in edema and swelling. They can have problems with their output becoming a decrease, and they're not perfusing very well. These are the common reasons why they're coming into the hospital for in a lot of cases. Other things as well, emotional stress, infection, all that can be playing a role here as well. So one of the big things we're focused on with CHF as far as non-pharmacologic therapy we can do is try to limit their salt intake, right? So by holding on to less salt, they hold on to less water, right? So that's going to be a big thing we can do here is by getting less salt coming in and less fluid coming in, they're going to have less of it kind of sticking around in the body. So that's one of the big things we want to focus on. And again, by having less of that fluid around, they're going to be able to get around a little bit better. Physical activity is going to help them in the long run. But again, we're in a pharm class. Let's focus on the drug we're going to use for these patients here. So the big thing I'll talk about with CHF is that there are some drugs that are good for symptom management, some that are good for mortality. It's good to know the difference between those two, because again, the ones that help with mortality, they have to be on, right? Or they should be on. The ones that are just good for symptoms may or may not need to be on, depending on what their symptoms are like, right? So again, the first thing we're going to talk about is going to be diuretics. Okay, diuretics are going to do what for us? They get rid of that fluid. They get rid of that salt. We know the side effects thereof. We know all the problems that go along with diuretics. We know their effects. It's good. I don't have to belabor those points here. The main thing I want to focus on is that while thiazides are good for hypertension, not very good for getting rid of all that fluid. Loops are going to be your mainstay of therapy here, right? And this is only for symptomatic management. There's no mortality benefits with these. Okay. So again, how do we determine if a patient is holding on to too much fluid? Their weight's a big one, right? So again, you want them to monitor their weight. If they're adding on a pound or so every single day, they know they're holding on to more fluid. You may have loop diuretics that may be on all the time, or you may just tell them, hey, take it PRN. If you notice the weight's going up by a few pounds a day, go ahead and take your loop diuretic, right? So there may be different ways you may be able to take these. Now, what is a good, or what is something they need to worry about electrolyte-wise if they're taking a loop diuretic? Hypokalemia is going to be a big one, right? Potassium is going to be a big role to play here. Because again, what you're going to find is these patients, oftentimes is CHF the only problem they have? They got other issues too. They may have diabetes, they may have renal failure, they may have other issues that to think about. So potassium is going to be playing a big role here. A lot of the drugs we're going to see here are going to affect potassium, so we're going to start thinking about this as well. Okay, so again, loop diuretics typically going to lose potassium in those patients. So again, only for symptomatic relief, not mandatory therapy. If they're not having issues managing their fluid, if salt, decreasing salt intake, decreasing fluid intake is good enough for them, they don't have to be on a loop. It's fine, right? However, for acute decompensation, they're coming in, they're just severely demonous, and the lungs sound all junky because they're full of fluid. That's where loops are going to be really good to help get rid of that extra fluid. And what loop might I use? Furosemide is a really good one. Lasix, you use bumetanide, you use torsemide, any of those are going to be totally fine. Okay, any loop will work there. Now, ACE inhibitors are going to be one of the mainstays of therapy here. We do know that ACE inhibitors decrease mortality with these patients. They need to be on an ACE inhibitor at the very bare minimum. Now, if they can't take an ACE inhibitor, A or B is going to be fine as well. Okay, so these are going to be good because they're going to decrease the preload, right, by decreasing the renin-angiotensin effects on the kidneys, right? They're going to decrease the afterload by decreasing blood pressure. They help to decrease that sympathetic activation. The big thing, and the reason why we like to have it on for mortality standpoint, is it helps to decrease that remodeling, that hypertrophy that occurs within the left ventricle, so you can preserve LV function for longer. This is why they need to be on these drugs here, right? So we see that we have a slowed progression, and we have a decreased mortality. That's the reason why we like ACE inhibitors here. Okay, so again, they're going to have improved exercise tolerance. They're going to have better hemodynamic responses here, fewer admissions, prolonged survival. These are why we like ACE inhibitors. They need to be on these drugs. Okay. Now, of course, what do we worry about with these patients? If they have concomitant renal failure, you have to be careful initiating an ACE inhibitor because again, we know it's going to decrease their function initially. However, how can we mitigate that? Start slow and low, right? So again, it's going to be the mainstay with a lot of these drugs here. They need to start low and slow because these patients can be particularly sensitive to these drugs here, okay? Hypotension. What does ACE inhibitors do to your potassium? Elevates it, right? So again, that makes sense. So it's okay though, because what if you have a loop diuretic on board and an ACE inhibitor? Maybe they'll cancel out a little bit. Again, this is why you have to monitor for these things to see how they're doing from that standpoint. And again, we mentioned the cough, the angioedema. If they're having incessant cough, what can they do? Switch to an ARB, that'd be totally fine. Good. Now, beta blockers. Now, what do you think? Does beta blockers make sense in CHF? Why? It decreases heart rate contractility. My patients have an issue with their ejection fraction. That sounds deleterious. So it decreases oxygen demand by the heart, but we're not talking about angina at this moment here, right?
It also dilates your coronary. Oh no, sympathetic BP.
Yes, sir.
More diastolic flowing, so you can pump out more efficiently.
Absolutely, yeah. So it helps with the efficiency of the heart, essentially, right? We're slowing things down. We're letting the heart give it more time to try to fill longer, to get that better fill going on, so that way it can pump out more blood there, right? So we're going to find that acutely giving a patient a beta blocker is going to be not great, right? If you give them a big full dose beta blocker right off the bat, you're going to decrease that contractility. You're going to cause an acute decompensation. Not good. Okay. However, we do know that by giving patients beta blockers with CHF over time, you're going to decrease mortality. And you have to start very low dose and titrate up very slowly to what they can tolerate. Okay. To be careful with these, because again, we do know that there's going to be negative inotropes and chronotropes. You have to be careful with these patients. So oftentimes they're initiating these when they're actually in the hospital, and you can actually monitor them right away. You're monitoring their weight, monitoring their fluid status, monitoring the EF, all those sorts of things there. Now there's 3 beta blockers that have proven benefit in these patients, and these are actually ones with indications for it. There's carvedilol, which we talked about. What type of beta blocker is that? Third generation, good. And it has some extra alpha blocking abilities, which is nice from that standpoint because these patients are oftentimes hypertensive, right? So that's good. Metoprolol succinate, which is the XL formulation, so that's specific for that one, right? And then we have bisoprolol or Zebeda. Okay, any of those are going to be fine. So metoprolol and bisoprolol are what? Cardioselective beta blockers, right? So they're beta 1 selective. Yes, ma'am.
Okay, because I know that the carvedilol has the alpha 1, properties too. But do those as well, or
they don't? They only affect the beta 1 blocker or the beta 1 receptors. However, we do see in the studies though that they have similar effects as far as mortality goes for these patients.
So is it just because we've done studies on those that we don't? Okay.
That's how they get an indication, basically, right? So if a company says, "Hey, I want to use my drug for heart failure," they have to have studies they take to the FDA and say, "Hey, I want an indication for this." They can use anything off-label, but to actually get a labeled indication, you have to go back to the FDA, right?
Evidence-based.
Okay. Absolutely, 100%. Yep. So again, patient needs to be stable before you start a beta blocker because we know acutely these can cause them to decompensate and start very low doses. Okay. Now notice we can't use any non-dihydropyridine calcium channel blockers here. It's really only beta blockers is what's going to be the mainstay here. Again, usually like 6 to 8 weeks you're going to be titrating. So a long time you're titrating these patients up to see how they tolerate it. Again, if they're having worsening symptoms, go back down. Go back down a little. You can always go back up later if they can tolerate it. But again, be very careful with these drugs because they can be pretty sensitive to these. So, as I mentioned, they have improved exercise tolerance. They're going to have better hemodynamic improvements, especially in ejection fraction, because now you're giving the ventricles longer time to fill up, and they'll have a better chance to kind of squeeze that blood out, right? Because again, you're decreasing the sympathetic effects there, so you're getting it slower, has longer time. It's good. And so we see there's less hospitalizations, less need for transplant, less mortality, all really good things. So beta blockers, ACE inhibitors need to be on CHF patients. Okay. Again, should be first line for class 2 through 4, so that's the majority of your CHF patients who have been diagnosed. And again, irrespective of symptoms, probably should be on ACE inhibitor and beta blocker. Okay, do they have to be on a loop diuretic? No, not there's a problem for them, but they should be on an ACE inhibitor and a beta blocker. Okay, a new drug we have here is called Digoxin. So this is actually going to fit into the antiarrhythmics we'll talk about in a few moments here. But Digoxin is actually a naturally occurring compound. Does anyone know what plants this actually comes from? It's a very old drug. Let's talk about plants when they pop up here. So if you ever see, if you're ever going down, say like the 417 or something, you see all those nice oleanders. They're growing on the medians. Nice pretty flowers there. Those actually have digoxin-like compounds in them, right? The other ones like lily of the valley and foxglove and things like that. But this is a very old school sort of CHF med that we were using for decades and probably hundreds of years, as the case may be. But basically what this drug does at the baseline level is that it inhibits the sodium-potassium pump in the myocytes. Okay, so what does the sodium-potassium pump normally do? It pumps sodium out of the cell. It pumps potassium into the cell, right? Against the concentration gradient, which is why it requires ATPs. That's what the sodium-potassium ATP pump, right? What does that do for us? Eventually it'll help with the influx of calcium, but what does the sodium-potassium pump at baseline just do for us normally in the myocytes? They maintain the resting membrane potential of those cells. We're going to get to the cardiac cycle here in a few minutes when we talk about the antiarrhythmics, but they maintain the resting membrane potential, okay? So by inhibiting that, what you're going to find is, so again, this pump here is going to be inhibited. You're going to find that you're going to have a lot more sodium building up within the cell. So the myocyte says, well, I want to get rid of that sodium somehow. So what it's going to do is trying to use this pump here, this antiporter, where it's going to be shuttling sodium out of the cell, but then bringing calcium into the cell. And what does calcium do in muscle cells? Increases contractility. So the thought was, and what we were using this for a good long time was, well, if the patients are having an issue with contractility, let's give them something to try to get more calcium in the cell to try to cause that increase in contractility. Okay. So digoxin was used like that for a good long time. We'll see it's used a little bit differently nowadays, but that's kind of what we're shooting for when we're looking at this contractility issue here with digoxin. Okay. So again, we're using it as an inotrope. It could be a positive inotrope because again, it's increasing that contractility there. That was the old way we were using it for a while there. Nowadays, we realize there's some kind of other ancillary effects we're going to use it for. This is kind of neurohormonal effects here. And so basically what it can do is decrease sympathetic activity while increasing parasympathetic activity on the heart, which is good. Again, that's going to slow it down and give it time to fill a little bit better. It can resensitize the baroreflex. What does that baroreflex do? It maintains that blood pressure, but remember we said with these chronically hypertensive patients that gets reset. They have a new set point for the baroreceptor response. That can help to reset it a little bit, get it back down lower, right? And then decreasing that renin-angiotensin-aldosterone system. So all these are really good from that standpoint. So as I mentioned, again, these are kind of showing you the main effects you're going to see. But again, by increasing parasympathetic activity on the heart, on the AV node, guess what that does to the heart rate? Slows it down. Decreasing sympathetic activity is going to slow it down as well. And again, you're should get an overall increase in cardiac output from this drug.
Is this going to work kind of against beta blockers slightly?
It does not work against the beta blockers because again, it's actually working in synergy in concert with the beta blockers because these beta blockers are blocking sympathetic activation. This is also decreasing sympathetic activation in the first place, right?
Okay, because I thought you said that it increases contractility.
It does. So from that standpoint, beta blockers are a negative inotrope, but this actually helped to increase that squeeze there a little bit. So again, they may think they'd be working against one another, but overall, because of the neurohormonal effects, that's more important. That's why we like these better now or that's why we realize they work so well for CHF, is because we realize there's other effects that were not just a contractility issue, right? Yep. So anyway, so again, what we see is decreased remodeling, increased perfusion of tissues, all really good things for CHF patients. And notice this one is actually going to be a narrow therapeutic index drug. You have to monitor levels for this one. And again, nowadays we shoot for levels of like 0.5 to 1. We used to shoot a little bit higher back in the day, but now we shoot for lower levels and still get the same benefits out of this. Now again, I'm not going to have you memorize the levels specifically. I will give you a reference range on a test if I'm asking about a level specifically, but just know we do monitor this one. So what we see is benefits in their symptoms, improved exercise tolerance, quality of life goes up. However, there's no survival benefit. So there's no actual need for a patient to absolutely have to be on this. And in fact, due to the issues with the clearance of the drug and the kinetics of it and all this stuff, a lot of patients you may find they're not going to be on this. A lot of older patients, though, maybe maintain on this for decades. It just depends. So it's better as kind of an add-on if they're still having symptoms, that have not improved with the ACE inhibitors and the beta blockers. This could be a useful kind of third-line sort of agent you may be adding on for those patients. Okay. And we'll see that this is also used for AFib. So this can be useful if a patient has CHF and AFib because it helps to actually control that. We'll talk about that as an antiarrhythmic a little bit later on. So side effects-wise, again, this is why it's an narrow therapeutic index drug, a lot of side effects associated with it. So again, GI, you see a lot of anorexia, nausea, vomiting associated with it. But what's interesting, and this is actually one of the things you want to educate patients on, is to the visual changes. And this can be the first sign that their levels are too high is when they start to have these visual changes. And they may not associate it with the drug, but if you educate them on that, they can make that association. So they can develop photophobia, blurred vision. The unique thing is what we call xanthopsia. Anyone know what that means? Yellowing of the vision, yeah, absolutely. So if you have bluing of the vision, what do you call that? Bluopsia? No, cyanopsia. But yeah, so anyway, we'll talk about that later when we get into erectile dysfunction meds that actually occurs there. But this is called xanthopsia. So the yellowing of the vision, they get halos around lights, and so they describe the kind of yellow-green kind of halos around lights. That should key you into, hey, digoxin toxicity. I should be thinking about that. I should check a level, make sure it's not too high for those patients. So other things you can see some CNS symptoms like delirium, confusion. Again, those should also be kind of cluing you in that, hey, maybe the levels are too high of this drug here. So the other thing to think about is also going to be the cardiac effects that this is going to have. So really when you think about digoxin toxicity, any arrhythmia can occur with these drugs, right? You can see bradyarrhythmias, tachyarrhythmias. Most often, though, you will see bradycardia. You see some heart block associated with this one. And so you can see that that's most common. However, especially when you have really high levels, and again, that's where I see this most often is patients who, are not clearing the drug very well. Their levels are very high. We see all kinds of crazy rhythms that can come about from digoxin. But just know bradycardia is most common.
Is it an anti-rhythmic drug or anti-rate control or rhythm control?
This is more of a rhythm control sort of thing. Yeah, we'll talk about that a little bit more when we get to the antiarrhythmics in just a few moments here. But yeah, definitely more of a rhythm control sort of thing. Yeah. Exactly, yeah, because again, we're altering that sodium-potassium pump. So by altering the resting membrane potential of that cell, you're going to be increasing your chances to have some of these action potentials here, and you can see things like different arrhythmias that can pop up. So we'll talk about some of those briefly. But again, the contraindications that they already have existing advanced AV block, this is just going to worsen that. Severe bradycardia, all these things are going to be making it less likely you want to use this drug. The other thing to see as well is that when you have hyperkalemia, this increases your chances for arrhythmias. So again, if a patient's on an ACE inhibitor, and maybe you put them on another drug that increases potassium, maybe on a potassium supplement, and their K is already 6, this is going to increase arrhythmia seen with digoxin. But also think about it. If I'm inhibiting the sodium-potassium pump that normally brings potassium into the cell, and I block that pump, what would potassium levels on the outside of the cell do? They go up. So guess what? This can cause hyperkalemia in and of itself. So you got to watch out for those levels and make sure you're not going to drive them too high, increase your chance for arrhythmia. Okay?
So you said hyperkalemia can lead to digoxin toxicity?
Yeah, and this can actually worsen the hyperkalemia a little bit as well by blocking that sodium-potassium pump. So we'll see patients who are their levels are too high, and they will have hyperkalemia associated directly with this digoxin. But again, if they have renal dysfunction, they're going to be hyperkalemic anyway. So you got to be really careful with this drug here. Okay, hypercalcemia can worsen this, hypomagnesemia. So any of these things can exacerbate those arrhythmias or that risk there. And again, if they have Wolff Parkinson White, you do not want to use this as well. If the levels are too high, how can I reverse this effect? We have an antibody for it. And so this is called digoxin immune fab, or Digibind. We'll give this, and it's an antibody designed to bind up the digoxin, and then you just clear it through the kidneys. Very effective, very rapid reversal of these effects here. And we'll use it pretty frequently if you have a patient who is developing some of these arrhythmias, and we just need, they're hemodynamically unstable. We'll give this drug to them. It'll bind it up within an hour or so. They're back to normal, basically, which is nice. Yes, ma'am.
So you know how albuterol decreases like if someone's hyperkalemic, but it can also cause like tachycardia. So you wouldn't ever use this in someone like that, right? Because they're already having like rhythm issues.
So using this for what indication specifically, I guess?
So like you know how you said that this can cause hyperkalemia,
yep.
Right?
Mm-hmm.
I remember you saying that people who come into the ER with hyperkalemia sometimes you do albuterol when you're waiting, right? Can you do that in this instance too? Or?
Yeah, because Right, so kind of take the whole picture into account, right? So if I had a patient who, say, was digoxin toxic, right, and their potassium is, say, 6 or something, right? They're starting to have PVCs on the EKG, and I'm like, okay, I see the myocardium's aggravated here. You know, I may give them some albuterol to try to get the potassium down, but that's kind of a short stop, right? It's kind of a thing that I'm not going to do as definitive sort of therapy. That's if I just don't have any IVs, right? I might do other things like give them sodium bicarb to drive that potassium into the cell, right? I might give them something like insulin and glucose to drive that potassium into the cell. We can talk about hyperkalemia at a later date, but there's a whole litany of drugs we can use to try to get that potassium level under control there. And we may use it occasionally for these patients, you know. But oftentimes, if I give them the Digifab, it'll actually bind up the drug, and they also actually see potassium levels go down because now that sodium-potassium pump can start to work again. Yep. Mm-hmm. So the next set of drugs here is going to be our aldosterone antagonists, and the two big ones we have, spironolactone and eplerenone. Now, these are going to be indicated for more severe, more progressive CHF patients, so in grade 3 or 4 heart failure. We do see mortality benefits here, so these are good to have on if they are stage 3 or 4. However, there are going to be some contraindications here. If their potassium is already above 5, do not give it. If their serum creatinine is above 2.5, do not give it, because again, they're more at risk for having that hyperkalemia. Okay, so do not administer these drugs in those cases. Remember the side effects associated with the aldosterone antagonists. Remember, eplerenone is a little bit better from the gynecomastia standpoint for those patients. Okay, again, slow progression of CHF, good to have on for, again, more progressive sort of patients. Okay, now if you have a patient who comes in and they're having acute decompensation, I want to give them something to try to get that contractility back up. And so these are called inotropic agents. These are positive inotropes I can administer to try to increase that contractility. Because again, if I know they're coming in with an acute decompensation, their cardiac output's not good right now. So I need to get that contractility up to try to get them perfusing a little bit better. So this is where you have drugs called milrinone and enamrinone. And basically what these are doing is these are phosphodiesterase inhibitors. Note though, the last phosphodiesterase inhibitors we talked about were the erectile dysfunction meds. That's for PDE5. This is PDE3. So just know there's different isoenzymes and they do different things throughout the body. So when you think about PDE3, this is affecting the heart mainly. So basically by blocking the metabolism of cyclic AMP is one of those secondary messenger systems, right? They actually increase that contractility of the heart pretty well. They also help to drop the blood pressure a little bit, which is nice because most of the time CHF patients, their afterload is too high, right? So again, this is good to try to get the pressure down a little bit, help the heart squeeze a bit more strongly, and that will help to get that perfusion up in those patients. So this is where you use milrinone or enamrinone. These are typically IV agents we'll administer via continuous infusion to try to get that contractility up. So again, they're going to directly stimulate that myocardial contraction. They're going to have that nice arterial and venous dilation, so that will help out with the blood pressure if they're hypertensive, and it will decrease afterload and increase cardiac output. So very good from that standpoint. So again, we'll use this for short-term, for decompensated heart failure. We don't like to use it for long-term because, again, if I'm directly stimulating the myocardium, what could I see? Arrhythmia can occur, right? So constantly stimulating can lead to potential arrhythmia that can develop there. So you want to be careful with that. Ventricular arrhythmias are a risk. And again, these are patients who probably have a screwed up myocardium anyway, either due to infarction or whatever happens to be. Hypertrophy can affect this as well. So again, arrhythmias are going to be a bigger risk for them anyway. Okay, another one we have is called dobutamine. This is actually a direct beta-1 agonist. So this actually stimulates the beta-1 receptor to try to increase heart rate and also contractility. So you can use that sometimes to actually help with decompensations. And there's also another one called dopamine. Dopamine is a drug we'll talk about as a vasopressor a little bit later. Vasopressors just mean it's squeezing down on the vessels to increase blood pressure. Sometimes we can use this as well due to it affecting the beta-1 receptor. So again, just other options you may see being used for these patients here to try to stimulate that contractility to try to get that perfusion back up. Okay, any questions on CHF? So again, what drugs should they be on? ACE and beta blocker. They couldn't take an ACE? A or B is totally fine, right? They need to be on a loop? Not always. Do they need to be on digoxin? Not always. They need to be on a aldosterone antagonist? Maybe. If it's stage 3 or 4 and they don't have any contraindications, then yes, they should be on it. Okay, good. So moving into the antiarrhythmics, let's get into the cardiac cycle. Okay, so what do we know about the myocardium as far as the muscle goes? It's striated muscle. Is it voluntary muscle? No. I mean, I have really good control and change my heart rate. I think really hard about it. Most people don't, right? And so it's going to be one of these things where it's an all or none sort of phenomenon, right? So again, once it has a signal to have an action potential, it's going to beat within this very nice concerted sort of effort here, right? I call that a functional syncytium. They're able to transmit that electrical impulse very systematically, in a very nice regimented way, so that way you get a nice controlled contraction of the myocardium. Now again, does the whole muscle just all contract at once? No, it needs to be very organized, right? It needs to go from the bottom up, right? Because again, you're going to find that the signal starts where? The SA node is going to go down through the AV node. It's going to go down and then kind of depolarize out throughout the Purkinje fibers and the bundle branches, and it's going to go down from the bottom of the ventricles and squeeze up, right? Because again, that's where it needs to pump the blood to, right? Especially out of the aorta, right? Or out of the left side. So anyway, so we're going to talk about slow response cells and fast response cells. Slow response cells are our pacemaker cells, okay? SA node, AV node. Now, are those the only pacemaker cells we have? No, I could take out the SA node and the AV node, and I could still have something like the bundle of his. I could still have the Purkinje fibers. You'll find that they're progressively slower and slower, but that's good because we want the one that's the fastest to be setting the rhythm of the heart, right? So that's why I like the SA node to be the fastest one. It will kind of set the rhythm for the rest of the heart there, okay? The fast response cells we're going to see, though, are going to be the things that are responding to the action potentials coming about from the pacemaker cells, okay? We'll look at the differences between those in just a few moments here. But let's look at the actual EKG cycle here. So we see the P wave is what? Atrial depolarization, right? So that's where the initial spread of the action potential is going to occur here. This is where you see the SA node is going to be causing the initial action potential. You see the atrial muscle responding to this. Notice the differences between these cells here. Notice the fast response cells. Once they get that impulse, boom, potential goes up tremendously, right? And see how high that goes just immediately? That's atrial muscle right there. Versus the SA node, we're going to see it's going to be a little bit slower response. We're going to see how that differs in a few minutes here. Next, we're going to have the AV node kind of getting triggered here. And then what do you see next on the EKG? QRS complex, which is ventricular repolarization, right? So then you're going to see our basically these other fast response cells depolarizing. And then what do you see next? T wave, which is going to be repolarization of the ventricles. Okay, so we're going to get into specifically talking about how all these are going to be functioning together in just a few moments here. Okay, so let's look at the fast response cells. These are the cells that are going to be responding to the action potentials coming about from the pacemaker cells. Okay, so there's a couple different phases here. Have you guys covered this already? Huh? Well, I think I did a little bit last week, but I think we're more talking about the slow response cells. Now we're talking more about the fast response cells because where most of our antiarrhythmics are going to be working at specifically. Okay, have you guys covered this in other classes though? Okay. I see one head shaking yes, and I see a lot of no's, but so I assume you guys are. Okay, so not from, okay. So you're going to get my input on it, right? You're going to see my perspective on things. Huh?
Yeah, you're the one.
Okay, so hopefully we'll get this elsewhere, because again, this is really important stuff, so it's good to hear it a couple of times, okay? So anyway, so looking at the fast response cells, again, that's why I spend so much time on cardiology. It's so important, right? Again, if you don't have a heart functioning, guess what? You're dead. That's why it's so important. Anyway. So phase zero is this initial depolarization that happens here, right? So again, a signal comes from the SA node, the AV node, anywhere, and it's going to trigger off one of these cells. This could be in the atria, it could be in the ventricles. It all functions similarly, okay? So again, you're going to find that once that action potential comes along, it's going to trigger off this depolarization, okay? Now, what do we call this phase right here? What do you call this when it's just kind of sitting there resting along, nothing triggering it? Resting membrane potential, okay? And again, by changing that resting membrane potential, you can change how likely it is to see this cell trigger off an action potential, okay? Anyway, so looking at this, notice is normally negative, okay? That means we have a lot more negative stuff inside the cell, a more positive stuff on the outside of the cell, okay? So when you get this initial depolarization, what causes that? Well, basically, it's going to be an influx of positives into the cell. If you think about your normal basic metabolic panel, what's the highest concentration of positive ions outside of these cells? Sodium. Sodium's level 135 to 145, right? So very low levels within the myocyte, very high levels outside of the myocyte. So when you open up those channels, guess what? Sodium floods in along the concentration gradient. It's passive, right? This is a passive process here. It's going to flood in and cause the potential to go up very high, okay? That's good. Next, we're going to have phase one, where you're going to have a little bit of outward potassium, right? Potassium, actually, if you were to measure the levels of potassium within the cells, it's about 135 to 145, very similar to what the outside sodium levels are. Remember, I said we're salt-wrapped bananas, basically. Remember that analogy? Same thing is the thing here. So when I open up potassium channels, they will flood out of that cell along the concentration gradient, okay? So this is why you see this little notch here, this little dip happens, because we're having a little bit of flow of potassium out. We're also having a little bit of chloride flowing in. So negatives coming in, positive leaving, you're going to see a little dip there, okay? Next, you're going to see this plateau phase that occurs here. This is where you see the actual contraction that occurs here, right? Because we don't want just a quick thing. We want it to squeeze, get that blood out, and then relax again. So this plateau phase is caused by inward calcium. So phase two is inward calcium coming into the cell. And calcium, we know, does what in these myocytes? It's going to cause release of sarcoplasmic reticulum calcium, and it's going to cause actin and myosin to bind together, and boom, we have our contraction, okay? This is where calcium is so important for this stuff, right? So calcium is going to come in. Next, though, I need the relaxation to occur. So I need the calcium to get recycled back into the sarcoplasmic reticulum. I need to start to reset the cycle again, so that way I can get back down my resting membrane potential. So I'm going to do that by allowing potassium to flood out of the cell. So this repolarization phase occurs by letting potassium out. So right here, it's phase 3. Potassium's leaving the cell, and then now I'm back at the resting membrane potential. Okay, this is where the sodium-potassium pump is going to be maintaining that. So sodium-potassium pump is going to be bringing potassium into the cell against a concentration gradient. Sodium is going to be leaving the cell out against a concentration gradient, and that maintains my resting membrane potential. Now the cell is ready to have another action potential come along, and the whole thing starts over again. Okay. Now, have you guys heard of refractory periods? What is a refractory period? Yeah, you cannot have another action potential occur here. Now, there's a relative versus absolute refractory period, right? What does a relative refractory period mean?
You can maybe get it if you really need it.
If there's a strong enough signal, something can cause another action potential to occur. The absolute refractory period is what? Nothing can come along, right? So again, depending on where you're at, the absolute occurs first, and then later on you'll have the relative refractory period. This is where a lot of arrhythmias come about, and where a lot of our antiarrhythmics are going to do is trying to alter those refractory periods, okay? So that way we can prevent things like ectopic foci or accessory pathways from trying to trigger off these cells too early, leading to an arrhythmia, okay? Keep that in mind. Again, this is kind of showing you just another pictorial example where the different ions are flowing. But again, we go back and review that, and you'll see that, okay, sodium's coming in during phase 0, potassium's coming out during the repolarization, sodium-potassium pump's working to maintain. You'll kind of go through it again and see that where the ions are actually coming into play here. And this is important because this is how our antiarrhythmics are going to be working, by affecting things like sodium, potassium, etc. Okay. Again, you see sodium coming in during phase 0. You can see that we're going to have a little bit of potassium leaving there during phase 1. Calcium is going to be the big thing for phase 2, causing that plateau phase to occur there. And then potassium is going to be leaving again when you're having phase 3. That's that repolarization that occurs, and the sodium-potassium pump maintains everything at that resting membrane potential. Usually about -90, but it can change depending on several factors. Okay, I mentioned there's relative and absolute, so we already covered those. We know exactly what those are. Now, the slow response cells, I've covered this briefly last week in talking about what type of drugs. What drugs were affecting these pacemaker cells? Non-DHPs like calcium, verapamil, and beta blockers, right? So again, these are the big things affecting these slow response cells like the SA and the AV node, and that made sense based on things like by blocking calcium influx, I slow down the whole process, right? That's how the calcium channel blockers are working, right? Or by doing things like affecting cyclic AMP, I can change the resting membrane potential and affect how the beta blockers are going to be changing this pretty significantly, right? By affecting things like potassium efflux and whatnot. But basically just know that instead of sodium coming in to cause the depolarization here, it's all calcium. But also notice here, notice the line here, it's kind of leaky, right? Notice how it's kind of gradually going up on its own. By affecting that, by affecting how fast or slow that's going, once it gets to that critical threshold, that's when the action potential occurs. So if I were to make this more negative, what do you think would happen? It would be slower. It would take a longer time to get that threshold and then have an action potential. If I were to make this more positive, what would happen? I'd have a lower threshold, right? And that would be easier to have an action potential. So say, for instance, I'm in a fight or flight response. I'm releasing all this norepinephrine onto the heart. What do you think that does to this resting membrane potential? It's going to make it more positive. That makes it easier to have an action potential. That's how the speed of the heart goes up, because you're hitting that threshold more quickly by changing that resting membrane potential. If I were to have something like a beta blocker on board, though, what do you think it does? It makes it more negative. It takes a longer time to get to that critical threshold. So now you're starting to see how these are affecting it, right? But the big thing here is calcium's coming in, and then the repolarization phase is mainly going to be due to potassium leaving. Okay, so that's going to be similar here as well. And again, phase 4 still have the sodium-potassium pump working. However, the leaky sodium current's a big thing that's going to be helping that that levels rise up to that threshold, and then boom, your action potential happens there. Okay. Again, just another slide just kind of showing you how this is working. Calcium's coming in, and then you're going to find potassium leaving to cause a repolarization. Again, that's the leaky calcium or leaky sodium channels here is what's going to lead us to, again, eventually get to that threshold. Okay, so principles of antiarrhythmic therapy here, right? So one, you want to identify and remove any kind of precipitating factor here. So if they're hypoxic, what do you want to give them? Oxygen. Very good, right? If they're ischemic, try to reestablish flow, right? If they are having electrolyte issues, either take away the electrolytes or give them more electrolytes, right? So you want to fix the underlying issue here. And then once we have kind of fixed anything that we can fix on our own, this is where we want to try to either terminate an ongoing arrhythmia, or we want to try to prevent an arrhythmia from occurring here, right? So again, this is going to be a case where we're doing things like rate control versus rhythm control. This is where we talk about cardioversion, right? So you guys talked about cardioversion before? There's chemical versus electrical cardioversion. So electrical cardioversion, I shock the heart back into a normal rhythm. Chemical cardioversions, where I give them a drug to do the same thing, right? So again, these are things where we're trying to get them back to a normal sinus rhythm out of the arrhythmia that they're in already, right? So these are things you're kind of going to be looking at. Now, any antiarrhythmic can cause arrhythmias, so you got to be really careful with these drugs. These are very narrow therapeutic index drugs, just like a lot of the other ones we've talked about, like digoxin. Anything affecting the myocardium is going to be pretty dangerous here. And again, the electrophysiology of the heart is a moving target. It can change. It can be a little different for every patient, depending on what ischemia they've had, depending on their electrolytes, depending on all sorts of things. And so again, this is why this is very complicated. Again, I'm giving you kind of the baseline level of the drugs we're going to use here. But if you talk to like an electrophysiologist, they're going to go on for days and days and days. They had many years of fellowship just to do this stuff. So it's complicated. It's okay to have a hard time with it. So how do we classify our antiarrhythmics? It's based on their mechanism of action. We're going to find there's different classes, 4 different classes of antiarrhythmics we're going to talk about. Class 1, 2, 3, and 4. We're going to find that class 1 is going to be working on blocking sodium channels. We'll find there's a few different ones that fit into that category. Class 2 is our beta blockers. Guess what? You know a lot about beta blockers already. I think you may have a test on it coming up pretty soon, right? So you should know some stuff about beta blockers, right? Good. Class 3 is going to be blocking potassium channels, which is going to affect which phase of the action potential? The repolarization, right? Repolarization of that myocyte. And then class 4, calcium channel blockers. Specifically, which ones? Non-DHPs. Okay? And again, guess what? You know a lot about calcium channel blockers already. So again, you're seeing these drugs pulling double, triple, quadruple duty, as the case may be. We talk about beta blockers for like 6 different indications already, right? So it's good to know a lot about them. So looking at the class 1, the sodium channel blockers, you can break them down into 3 different categories, 1A, B, and C. This is predominantly going to be what phase of the sodium channel they're going to be affecting. We'll talk about this kind of 3 different states for that sodium channel, and there's different ways the drugs can affect that. So I'll show you some pictures of that in a moment. Again, I mentioned class 2 is beta blockers, class 3 is blocking potassium channels, class 4 is calcium channel blockers, and then we'll have some miscellaneous drugs at the end here we'll talk about. So looking at the sort of indications here. Now, this will make sense when you kind of think about the actual physiology of these drugs themselves. So when you think about things like a beta blocker, what type of arrhythmias is that going to be good for? Ones that originate in the atria, ones that originate in the ventricles, or maybe both? In the atria, right? Because you're thinking about these supraventricular arrhythmias. They're originating in the atria and they're communicating down to the ventricles. Now, for a good flow of blood out of the heart, do I need a really kind of well-functioning atria? Not really. That's kind of the wimpiest part of the heart, right? You know, most of the filling of the ventricles due to gravity anyway. The atria kind of don't really, not that necessary, right? However, if they have a very fast signal connecting from the atria down to the ventricles very quickly, and I'm not giving that ventricle time to really open up and fill, what's going to happen to that cardiac output? It's going to go down pretty precipitously, right? So I can give something like a beta blocker to slow that down. So even though the atria may be quivering, you're going to find that the beta blocker slows down that conduction so that the ventricles have time to fill and everything is good, right? So again, you're going to see that calcium channel blockers and beta blockers are good for supraventricular arrhythmias. They're not good for treating arrhythmias that are originating within the ventricles. So if a patient has a pretty nasty heart attack and now they're developing VFib or VTAC, those aren't going to do anything for you because the arrhythmia is developing in the ventricles, not in the atria, okay? However, we're going to find our class 1 and then our class 3 are going to be very good for affecting both atrial and ventricular arrhythmias. So that's kind of the big delineation you're going to see with that. And then our miscellaneous drugs will have specific indications there as we'll see. But that's kind of the main thing you want to think about. Class 2 and 4, beta blockers and calcium channel blockers, good for supraventricular arrhythmias. Class 1 and 3 can be used for either one, ventricular, atrial, or both. Okay. One thing to keep in mind. So the sodium channels, and we said the sodium channels are good for which phase of the the action potential? Phase 0, the initial depolarization. There's kind of 3 states for the sodium channel. There's the resting phase where no sodium can get in. There's the activated phase where sodium is actually is able to flow in along the concentration gradient into the cell. And then there's the inactivated phase. This is where you can actually cause, it's still open, but there's another part of the protein that's kind of blocking further sodium from coming in. This is part of that refractory period when you see this, right? It's part of that period where you're going to find that you can't have another action potential until it kind of resets back to the resting state again, okay? So we're going to go into our sodium channel blockers. 3 main classes here, class 1A, B, and C. Now, class 1A is basically going to try to slow down phase 0. And if you're looking at the changes here, the normal solid line here is going to be what the normal physiology, electrophysiology is. The dotted line is going to be what happens when you give the drug. Now, what do you notice about phase 0? Slowed down. It's not going to be as prominent as it was beforehand. The actual positivity of it is going to be down because the sodium is being blocked. So it's going to slow everything down essentially, right? And what do you think it does to the refractory period of that cell? it elongates it, right? It's going to have a longer refractory period. It's going to be harder for a reentrant arrhythmia to come along and trigger it too early, right? Because again, if you're extending that absolute refractory period, it cannot have another action potential. And by extending the relative one as well, you try to make it more difficult for that arrhythmia to occur. So this is why it's good for both atrial and ventricular arrhythmias. It can work for either one.
Where's the refractory period in the graph?
It's kind of it's hard to say, right? So again, it could be, I would probably say something like,
Where's the end?
if I can get the pin, yeah. So basically, you'd say like maybe like the absolute maybe in somewhere like around here, and then like the relative period would be somewhere like around here, right? So something like that, where you could have a strong signal come along and hit it during that period, and you could see another action potential. But if I were to extend this out, and notice here, say for instance, and again, this is not exact, but I'm just kind of guesstimating it. But if you were to look at the one with the drug effect here, maybe it's now ending here, and then the relative kind of extends all the way to here. So again, by extending that out, it's more difficult for that range of arrhythmia to actually come along and cause another action potential to occur. Okay. So anyway, so basically these are going to be more likely to bind to the open sodium channels. They're going to prolong that action potential and slow down at phase 0. Okay. They also slow down conduction quite a bit as well. And so we're going to find these are going to be negative chronotropes in a lot of cases, as we'll see in just a moment. So the 3 drugs, the fitness category, are going to be the acronym PDQ. Pretty darn quick is what I think about for class 1A antiarrhythmics. It's going to be procainamide, disopyramide, and quinidine. So we're going to cover those briefly here in a second. And actually, now that I'm kind of thinking about it, we only got about 5 minutes left. So let's go ahead and cut it off here. We'll come back and then finish this up next week. I think you still have classes, right? I know I'm dreadfully behind, but it's okay. This stuff is really important, so I want to make sure we cover it well, so that way you have a good understanding of the stuff and you get out there in rotations. So any questions on this stuff before I close it out? Okay.